Good morning, friends. Welcome you back in this session of endo microsurgery live from the Department of Microdentistry, part of Conservative Dentistry, GDC, Mumbai. I'm Dr. P.D. Joshi, and I'll be performing a surgery on a patient for the cyst removal and the removal of radicular cyst from the periapical area of 1-1 and 1-2. So here is my patient today, 18 years of age. Chief complaint is complaint of pain and pus discharge in the upper front region from the jaw, especially from the palatal side. She's got a swelling on the palatal side, and she had pain also in relation to that. She had a history of trauma 6 years back. That means she was very young, because right now she is just 18. And about a year or two back, she finished her endodontic treatment, but there was no relief of the symptoms after that. Since patient is very young, there is hardly any medical history. There is no medical history. Patient is healthy, so she is fit to undergo the surgery. The extraoral examination shows no abnormality. Intraoral examination shows discoloration of the tooth, and that could be one of the follow-up treatment for after the surgery, to carry out bleaching on the tooth to whiten it, and patient is very keen on it. You can see there is a class 4 Ellis fracture with 1-1. So that could be the beginning of the lesion, and swelling on palatal aspect of 1-1 and 1-2. So there is a huge swelling which increases and decreases as the discharge takes place, which also signifies that there would be loss of bone on the palatal side. The cortical plate might be missing. So this requires some special handling, because there could be open tract from the palatal side which may not allow the proper healing to take place. So we may have to cover that site either with a membrane or with PRF. So I'm looking forward to placing membrane over there. Right now there is no evidence of sinus tract. As you can see, this is the patient. Patient is already on the chair, and we are about to begin. These are some of the clinical photographs for you to see. You can see the tooth is very much discolored because of trauma. So both the central and the lateral are non-vital, were non-vital to start with, and they've been treated with endodontic treatment. You can see the teeth are getting pushed by the periradicular lesion, and there's a good amount of vestibule, so the flap reflection should not be a big problem over here. If you see the clinical radiograph, this is a clinical photograph of the palatal side, and you can see this part is having a swelling. So while curating the lesion, we will have to be careful about not perforating the palatal mucosa. So we'll have to support it while curating the lesion. Because we don't take a palatal incision and open from the palatal side, because it doesn't work well. The access is very difficult, the view is very difficult, and palatal mucosa bleeds quite a lot. So the surgery is nearly impossible. So most of the surgeries are done from the buccal side. That means we'll be having a through and through opening onto the periapical side as well as the palatal side, from the buccal to palatal. This is the that's a very big picture for you to see. This is the our endo performed on the 1-1 and 1-2. You can see the size of the lesion over here. It's also probably perforating on the floor of the nasal mucosa, so you may have to take care of that aspect as well. This is the CBCT report, and suspected radicular cyst with maxillary right central and lateral incisor. That's the finding on the CBCT. Here you can see the lesion is covering the central and lateral right up to the floor of the nose. Here you can see the lesion from the buccal to palatal and perforating over here, almost quite a huge perforation on the palatal side. Rest seems to be simple, and again this is the axial section, and you can see probably some amount of buccal plate could be intact, and if it is intact, after raising the flap we might be able to make a window. So if window is possible, we will make a window from distal of lateral to mesial of central, as you can see over here, this part, and from the incisal, little bit above the incisal area, cervical area, to the floor of the vestibule. So that size window, if we can open and keep it aside, store it in saline, then it will act like a membrane for us to support the clot underneath. Patient has been tested for all possible tests, and sugar and everything has been tested. Patient is fine. Whenever patient has this kind of lesion, active lesion especially, there could be a little bit increase in the blood sugar, which comes down immediately after the treatment. So not to worry about it. So provisional diagnosis is infected radicular cyst related to trauma. This would be possible to see, right from the buccal aspect to, or labial aspect to the palatal aspect, and we'll be taking an incision from the distal of the 2-1 to distal of 1-3 to raise the flap. Now, since the lesion is very big and covering right up to the almost up to the attached gingiva, so we will not be taking a Oxenbin flap. We will not be giving a papillary base incision, because it's not possible in this kind of cases. Papillary base may be possible, but best would be the intraclavicular incision, and then two vertical incisions, one on distal of 2-1 and other on distal of 1-3. So that would be the design of the flap, and then raising would be simple. Full thickness flap would be raised so that we can have the complete, and anyways generally in endo surgeries we always raise a full thickness flap. And then osteotomy, there is nothing like osteotomy in this, it's just the taking out the window. So if we can take out the window, it would be nice. If we can't, if the bone plate is too thin and crumbling, which is possible in this case, then in that case we'll have to just make do with the open site of the osteotomy, and just take care of the palatal mucosa, remove the lesion as much as possible in toto, and then do the retro preparation, root resection, retro preparation, and placement of MTA. I would be trying and showing you MTA instruments today, micromirror placements, how to view the apical part under the micromirror. I would try and show, and I will also try and show the MTA putty. So this also helps us to place it directly into the canal, and we don't need to have the map system. I have the map systems. I will try and show map system as well, how it functions. So we have variety of instruments which we can use to show you different approaches that might be possible, and that will help you to understand in different clinical situations. You can use these different instruments to help you get a better result. So Best of luck, friends, for a good viewing of the case today, and I hope you have a good internet. I'll be just taking over the case. Thank you. The first thing that normally we do is set up our microscope for the viewing. I hope you are getting a proper view on the screen. Okay. All right. So this is going to be my working position as far as this tooth is concerned, and you can see this is the area. I will try and show you now the palatal part. which also see there is a swelling over here, as you can see when I can palpate it, and little bit fluctuant, which is indicative of possibility of a cyst. So we'll be making an incision from the distal of the central to one like this in the concavity, and we'll be making it to the line angle of the tooth, preserving the papilla over here. Then we'll go intracircularly because it's a big lesion, and we will go to the lesion extends right up to here. So we go a little further than that onto the distal of the canine, and we'll take an incision in the concavity over here, and then we'll round it off at the neck of the canine, the cervical area of the canine. Local anesthesia. Yeah, if you have topical, nothing like it. You have cotton. Keep some cotton. So after I give local anesthesia, I'll try and show, run my microscope on the instruments for you to see, so that you will be able to see it. Applying some amount of topical. That's not some, that's lots. Opening mouth. Can we have a dustbin over here? One dustbin. Both highlighted. Okay. Idea would be to give sufficient local anesthesia to start with. So go very slow as far as possible. So I'll start from the canine area. You can also, give where is your external margin of your flap, and then come to the main site. I'm giving a little bit of local at a time to make sure that the entire tissue is infiltrated with local. Generally, this allows, this helps you to reduce the bleeding because this contains adrenaline. So you can give everywhere a small dose once the patient is partly anesthetized. Then gradually you can go deeper. Imagine you are right up to the floor of the nose because that's where patient's lesion is. You need to go deeper. Same thing on the lateral. and then you can give a little deeper, more close to infraorbital nerve. So this is my first round of local anesthetic on the buccal labial aspect. Now I'll be giving some on the palatal aspect. Now you start with the midline papilla, slightly palatal to midline papilla. You would have the incisive canal and foramen. So that's where, you know, if you inject, it will take care of a major part of the palate. People call it incisive canal block, but I just call it incisive. That's the injection you give in the incisive canal area. And go slow so that it spreads, and you should be able to see the blanching taking place. Key is to see the blanching all around. The tissue should not look very red if your local anesthetic is given properly. Of course, after some time it becomes pink once it is absorbed, but to start with you can see, and you need to go all the way up to the depth of the lesion, which I can see on the swelling over here. So that my entire lesion is covered on the palatal aspect. Also imagined, suture placement. So a little bit distal to your incision also you should give, because your suture would be going distal to the incision. And I concentrated more on the palatal side because there is a palatal perforation, so we are going to go all the way to the palate. And once we have raised the flap and opened and started curating, it will be difficult to inject on the palatal side because we'll be going straight into the socket. So make sure that this tissue is thoroughly anesthetized. Now what you do is give a slow infiltration into the lesion area, allow it to spread. अभी कुछ पता नहीं चलेगा. I'll do it after finishing the. This is even become blurred. Or okay. Fine. All right. So while we are waiting for the local anesthetic to work, I will try and show you the instruments that I'm going to use today, my armamentarium. Okay, I should be able to show you from here. So this is a retractor devised by Professor Kim from University of Pennsylvania. You can see there are sharp edges. This is to retract the flap and rest the sharp edges on the surface of the bone so that your flap does not keep on slipping from your hand. You can see even this has got some serrations over here. This allows you to rest your retractor properly on the surface of the bone, taking care of the flap. This helps you a lot in retracting the flap. There are two different designs for you to work on. Then I will try and show you the different retractors. You can see there are different designs for you to take care of. These are the flap periosteal elevators. You have large one, you have small one, pointed one, flat ones, rounded ones. So depending upon the location, you can use this. And it's double-sided. You can see there are different. You can see a hole over there. You can pass a suture through that in case you need to sometimes. This helps you in elevating the flap properly. I'll try and show you now the next set, which is the curates. Small, large, medium-sized, different designs, different angulations for you to reach in different parts of the lesion. All are double-ended, and many times in these kind of cases you need sometimes periocurates. So you can see these are periocurates. They will go around the palatal surface of the tooth for you to scrape off the lesion from the palatal surface of the root. So this helps you to go around the tooth quite easily, and that's why these are angulated this way. So these things you keep handy in case they are, and all of them are double-sided. So you have a right and a left, so you can go from right side or left side of it. This is a set of MTA packing instruments, as you can see, and carving instruments. So this one over here is a carver, and these are all angulated in a way for you to reach. You will be able to see them whichever we use, and double-sided. One side is the ball burnisher for you to smoothen or condense the MTA. You can see this particular angle. It's so handy to place condensed MTA into the apical part, and it's very small, so it can go into the canal as well. Right, so these are our instruments, and I think the patient's local anesthesia might have worked. I'll just refocus. Anything else worth showing? Yeah, we'll show the mirror and the gun. Okay, I would like to show you the micro mirrors that I'll be using. I'll just keep them over here so that I can focus on them. You can see this is such a small mirror. Now this helps you to view the apical foramen, and these are front surface mirrors. Of course, this has got scratches, so but this one is good enough for you to view. And we have this MTA gun, which we can use to, with the plunger. When you press the plunger, the MTA would come out. You can use as well this kind of a device to go into the apical area, but this is more handy because you can even bend it as per your requirement, because you get variety of shapes in that, right and left as well. So there's a complete set, but I've just brought, because today is the anterior tooth, so I've just brought for the anterior. And yeah, this is set up, and this one, this is okay. I can show at the time of surgery. All right. Okay, so we are ready. All these instruments, we'll be using some of them and you will see them in action. Have you tightened anything? No. You tightened anything? This is better. Now just tighten slowly, very slowly. That's it. Should not move. That's it. No, it's fine. Yeah, fine. Okay, so microscope is set, and it's comfortable for me to work in this position, so I can work like this. Now I'll be showing you one last thing that we use for microsurgery, and that is the blade. You can see 15C. So it's a smaller working blade and finer blade, so it gives you a finer incision. All right, so the case is well defined, so we can go from here, turn our incision up to here. I will go on to the distal, but I need to raise the frenum completely because I have to go right up to the floor of the nose, nasal floor. Now at this point I will turn the incision towards the tooth and then go into the sulcus, and you can see the 15C blade helps you to section this part much more easily because it's a smaller and finer blade and it can go around the tooth much more easily. So now I'm on to the lateral. I'll make sure that every attachment is severed so that the flap will reflect easily. And थोड़ा मुंह खोलिए आप. हाँ बस, thank you. And I'll be coming right up to here. That is distal of the canine. So I'll take a vertical incision here and go towards the cervical margin, preserving the papilla. At this point, you need to see that have you separated the fibers so that flap will go easily. You can actually run the blade in the reverse for you to see. Sometimes you think you have given, but maybe there are some attachments which are not severed properly. So you can go with the blade in reverse for you to see whether it runs smoothly, and wherever it doesn't run smoothly, you can give some more incision, separate the fibers. You can even check it with an elevator And you can see you can even use this blade for reflection. It works well for even reflection because you want a full thickness flap, so you're simultaneously, especially in the frenum area. The frenum attachment is very close to the cervical margin of the tooth, so you need to separate it well. So now I will use some of the periosteal elevators to reflect my flap. You can use a small one like this, and raise from the corners and then go you can reverse and use the curved portion. At this point, if you feel this is not separating easily, you can use the blade again to separate it, or you can use the other side to separate the frenum. Because sometimes, while separating the frenum, you can tear the flap. And here you can see there's some adherent tissue. Lesion is already perforated on the labial side, as you can see. There's not much of scope of making a window over here. If this part of the bone was intact, we could have made a window and placed it back after the surgery. You make sure that and you can see there is some discharge taking place. Even here there is a kind of a perforation. I'll be using a little larger periosteal elevator now to go to the base of the flap and go as much as possible into the just tighten this slightly. This is, yeah, that's it. So you can retract. Yeah, you use this. This will be more easy for you. Like this. So this is where the second part of the lesion is, as you can see over here, supposed to be infected radicular, so it is sometimes if there is a tension on the mucosa over here, you can relieve that as well, but try and go a little bit inside the flap so that even the suturing would be easy. So my central is here, so the lesion would be going all the way from here to the lateral and right up to here. As you can see, it's draining from there. This is where the drainage is taking place. Now is the time to start exploring and have the osteotomy done. So I'll be opening we can take an aspiration if we want over here to determine what is the content of the liquid, or we can just let it drain. Can aspirate. Can you just aspirate it out? So decompression is required over here so that there is a easy removal of the cyst. This area will open up easily. As you know, it's just a very thin bone covering the cyst. I'll try and decompress because that would help me to It's not coming into this. It's already drained. Okay, doesn't matter. You can even compress the palatal side. I think this needle is not aspirating. It's a thin one. You need a thicker needle for this. 18 or 20, 19 gauge. 18 gauge is ideal for this. Okay, just decompress it. Yeah, let it come out completely. Now I can use some sharp curette to open the window further before I can cut the window. I just want to see how much of the window comes out on its own. As you can see, it is separating and lifting. And keep some gauze pack over here so that it absorbs. You can see almost most of the window is opened up just by lifting it from underneath. So, you are trying to preserve the cystic lining so that you can remove it without shredding it much. Gauge. We can try. I can explore right up to the base of the lesion. I can see it's over here. Right up to the midline, I can go and explore my lesion. I need to look at where exactly is my floor of the lesion is over here. Aspirating. And I'm almost on the floor of the nose, nasal floor. So here you can see the lesion. And you can see, you can actually feel by separating the membrane of the cyst or lining of the cyst, where exactly are you reaching. Doubt whether it will now take up anything. It's empty. Okay, so now we can open the window a little more with our burrs so that we can remove the cyst. So I'll be using open it. Let it go down. Others, just lift this. There's one more set, उसमें round burr होगा. Just start this compressor. नहीं on. So I'm just exploring to see whether I have to open anything distally. But looks like we are just near the edge of the lesion. Easily, probably I'll have to open a little more to uncover the central incisor over here. There is this much of a depth of the lesion still pending to be opened. Anyways, I need to open it because I need to do retro preparation on the central. The root apex is somewhere here. I can open like this a little more so that we can see more clearly. If you want to use your retractor, it's fine if you're comfortable with it. Hmm. You can see the entire cyst over here. And this is where it's going to be its boundary for the upper part, the superior boundary of the cyst. Now I'll just, if the burr is ready, I can start opening the central area so that I can, sorry. Start the water. Right. So I'll be using a carbide round burr to lift the bone from here so that so this is a surgical aeroter I'll be using because it gives me a better view and the access. So I have almost gone to the mesial portion of the cyst, and the superior border also I am trying to open. And the inferior border. So now we can grab it and try to take it out. So you go underneath and try and scrape it out, and now you can release it. You can even hold it if you want. Yeah, so it's nicely held and we can just pull it out. Making sure that you are not pushing onto the palatal mucosa, otherwise you will perforate. I'm going a little bit slow over here to make sure that it separates from the palatal mucosa. Slowly and steadily the cyst is separating, and it's about to come out, as you can see. The last vestige is over here, which I will just try and separate. All right, so you can have a look at the cyst. And we'll be storing it in saline solution. We can just clean this part with saline, irrigate with saline, and then more or less do the retro preparation and finish the case. Go inside also. Beta. With the younger patient, it's immediately starts clotting as well, so it's good in a way. This is some betadine because there was a lot of drainage and infection because it was almost like a pus coming out. So you might have noticed Dr. Reshma over here is supporting the tissue because I'm just trying to remove the, now whatever is the adherent fibers and the lining might be still there, and we are just removing the last part of the palatal area. You can go around now the root, or you can actually do the preparation and then go around the root. So you can actually I will now open up that part a little more so that I'm ready for resection. Water. त्यातलं पाणी येत नाही. You can irrigate on the burr only irrigate. This bone you don't remove because that's holding the tooth and will not allow dehiscence to take place. I'll be changing the burr to do resection. Now I'm just blunting the root apex and reducing gradually. It's around 2 to 3 millimeters that we reduce. Alright, so my resection is almost done. At the same time, I will also try to keep my margins of the preparation smooth. I still can see a lot of tissue underneath now, so that has to be removed. I'm using a smaller one now so that I can go between the edge of the bony cavity and the osteotomy and the root surface so that I can cure it out. Same over here. There's a little bit over here. Take out as much as possible. I'll take a periocurate again, which can go around even the lateral now. You can see I'm going even on the inferior border and checking whether I can find any tissue anywhere, and I'll just take it out. There's a little bit on the mesial border which also I'll take out because my now I don't see anywhere anything. This is just the palatal mucosa and some fibers of the palatal mucosa. I'll just pull them out with tweezer instead of and at this point I will supplement local anesthesia a little bit, and I can place a pack for the bleeding to stop. There's hardly any bleeding actually right now, but while the local is being given to the patient, अभी 1 सेकंड में ठीक हो जाएगा। पूरा साफ हो गया। आपने देखा, सुना ना आपने मैं क्या बोल रहा था? some more local.
क्या हो रहा है? काट निकल गया। आप खोलो।
अभी तो खाली बंद कर रहे हैं।
अभी बंद करना है आधे घंटे।
We can put a pause pack of pause over here, so that we can. That also. So we'll just now reduce the bleeding so that it can allow us to do the retro prep. Gel form right now. What is this? Only plain gauze. This is the LA. LA. By the time that bleeding is arrested, I will just infuse some LA into the gauze pack. कम हो गया दर्द अभी? So the pain seems to have reduced now because I gave a little supplemental local anesthesia. Now we'll pack a bit of we'll wait for a minute, I think, and by the time we prepare for ultrasonics, let's prepare for ultrasonics and let her rest meanwhile, and MTA placement. अभी दांत को भर देंगे और फिर बंद कर देंगे। हो गया? तुम्हारा ऑपरेशन हो गया है पूरा। We can open this pack. I'm not sure which one will fit because we have not tested on this. हाँ माइक चालू रखो.
माइक चालू करो.
तो आपको क्या रखना है?
Yeah, I'm ready. Now can we have the micro mirror? Micro mirror.
Next one.
Okay, so I'll remove the pack and we can keep a smaller pack on the floor so that we can work on the below the root surface. We can keep. Like to show you the apical area. We'll have to hold suction close to the mirror so that it doesn't fog. You can finish your preparation. I will just keep a little bit of a gauze on the floor so that we have a better view of the cubic. Okay, so now we can examine the apex, and I'll magnify for this reason. You'll have to focus. Okay, now can you see a little bit of sharpness on the edge, palatal edge of the tooth? So I need to round it off. And let's examine the central also. And you, if you can't see it with this, you can still go with a smaller mirror. This is a micro mirror. You need to focus. Some focus. I'll magnify further. I'm going with still higher on the magnification for can even hold like this to examine the entire root surface. Sometimes you will find cracks, lateral canals and all that. Let's examine the lateral. Resection. So you can clearly see the lateral also in the mirror view. Now I will just prepare the apical part. So this is that tip. And I remove the gadapacha. Also go around the wall a little bit so that the wall is also, if there's any debris on the wall which was left behind, is cleaned. I can examine it under the magnification of the mirror. And you can see my preparation is perfect. I still need to smoothen this surface, which I will do it shortly. Let's do the other central. So the tip is designed to give you 3 millimeter of the apical preparation. Can you move, retract a little bit? Yeah, thanks. can stop the water, then patient will not move much. But there's a lot of water coming in her mouth, so she's. Okay, so my preparation is done. I will just change the tip to smoothen. Yeah, I can use burr as well, but I'll just change the tip to smoothen the apex. You just need a straighter tip. So I'll be using a straighter tip now to smoothen the sharp edge on the lateral that was there. And you can see I can go like this. And use this ultrasonic diamond coated tip or zirconium nitride coated tip. To smoothen. Idea is to make sure that the apex looks in the center of the preparation. We can remove the gauze. Now we'll be able to see more clearly. So you can see my preparation is right in the middle. Over here also there is a little bit of gadapacha which either can be condensed back into the canal or it can be removed with the same ultrasonic tip. So I will go with the ultrasonic tip and condense it now rather than removing it. Always work on your tray so that if you drop things, you drop in the tray itself and not on the floor. Unless you have a lot of equipment and armamentarium with you, you should exercise caution. So I'm giving a condensing force so that my tip is gone. We'll have to use another one. उसका स्केलर का reduce the speed the setting to 3 or 4 because we don't need such a high setting. So I'm doing a condensing action so that it condenses the gada percha on the floor, and now I'll be placing my even this is gone. I think the speed is very high. Okay, we can we can now use some of these instruments for placing MTA and condensing like this in the canal. You can also use this to condense your GP. But this is also used for placing MTA evenly into the canal. I'll be placing gauze piece again on the floor so that I can now place my MTA. I'm just making it smaller. I want space to work. No? And I will be using injectable MTA. A little bloat. So I'll leave the gauze piece first. And then at the end we can pack it. And you can also see that the bleeding is completely stopped and I'm able to work quite peacefully. A little bit of oozing of course will happen, but I'm able to work. So we are ready to place MTA. I'll be using there is a needle which is a smaller one. Or we can cut this into a smaller piece. We can cut it. That needle is better. I'll just cut this and see whether the MTA comes out of here. Give me that needle. Okay, so here is how my MTA comes out from the needle. As you can see, I can insert the needle into the canal. I can even rebend it if I want. I'll rebend it in the direction of my canal. So now I can easily enter into the canal. And keep it reflected. Yeah, thank you so much. And you can see I'm injecting MTA and let it come out, so it will fill the canal in one go, and I can just replenish with my MTA plugger. One which we used just now. So this plugger will push MTA and you can replenish some more so that you know that it is completely filled. And then you can use a carver to smoothen it. So this way you can see you don't have too much of excess over there to clean up later in the mesh that is created. I'll be placing in the other canal now, the central. So this is condensed, and just verify the condensation. Yeah. Now I just want to depress the gauze piece just slightly. And it is already packed well. So I can just replenish. I'll use magnification for you to see so that can you focus it? It's focused. Yeah. Okay, so I just depress the and replenish. And MTA is almost filled. And now I carve it out with my carver. This requires a little bit of smoothing with the carver. You know, it goes around. And even take out the excess with the same carver, and you're done. So it's ready for closure. Let's examine under the micro mirror our MTA placement. You can see the root apex is shiny and glistening, it's smooth, MTA is smooth, it's packed very well. Just magnify to see a little more. I need to pack a little bit over here, so I'll just place a bit over here. And then condense. This time I can use a ball varnish. Just check it up once in the mirror. So you can also wipe the surface so that you can see it dry. Give me some small. Normally, what I use is for cleaning the surface, I use the applicator tip of composite instruments, the composite buildup. All right, so it's a clean cavity, no bleeding, nothing, no perforation on the palatal part. We can just examine that once. Put a move color. Absolutely no perforation. So we can just close completely without using any grafting material. I was hoping probably I'll have to use membrane over here. I can use membrane on the floor, but I think I can use graft on the surface and then I can put membrane on top as well. Okay, let's do that. Thank you. I will place the membrane on the floor, and there is the membrane there. That's not the membrane, the other one. I'll cut in two pieces so that I can place one on the floor, one on the surface, and in between I'll place some graft. Even if we don't do anything, it will heal uneventfully. In this case, should we? I think we'll leave it because I think it's very clean surface and not add burden to the patient cost-wise. The membranes, graft materials can cost close to about 20-25,000 rupees to the patient. I don't want to add that cost to the patient, but technically it is possible to place a membrane on the floor and then a graft and then again membrane on the surface. We'll close the flap now. And we'll be using smaller sutures. The flap should close quite effectively without much issue, and start with the frenum area. Use tweezer to pull it out. Now we'll be taking a bite on the palatal side. Yeah. A little bit gone haywire. I'll again redirect the needle. Once the needle comes out on the other side, we can push it back from the contact point. Either we can push it with the thread itself. If the contact point is not very tight, we can just hold it like this and go, but the contact is tight, so I don't want to push too hard. I will go from the other side and come out and then take it out. Reduce the size of your other end so that it's easy for you to tie a knot. Push the papilla in its proper position and then tie the knot. And then once the flap is secured in position, the rest of the job is easy. You can even first close this side. And then you stretch this way. Stretch it with your fingers. Not too tight, just enough to close the edges, because this is 15C incision. can actually work with 5 or 6 0 over here. This is a little bit thicker needle. I'll be closing the papilla part first with a light in knot. The palatal bite is needed because what happens is sometimes with the movement of the lip, the thread pushes itself from the contact point and loosens up. So you don't want suture to loosen up. That's why you need a bite on the palatal side. If you want, you can even take a bite on the labial side, if underneath the, and that I do generally when I want to pull this mucosa downwards. So then I can actually, go like this. But I don't want to do it in this case because this is already in proper position. This probably is an open contact, so it can pass through, I think. Two horizontal sutures now on the vertical incision over here. Hmm. Yes, you can control bleeding with adrenaline. Um, it's quite effective and stops the bleeding instantaneously. But bleeding was not a major issue in this surgery all throughout, except for once or twice we had to wait. But I think it was just about 2 minutes and we didn't use anything to stop the bleeding, just the pack. This is the last one, and I hope I can manage to take a bite properly. Another thing you must learn, and I didn't get it, is the needle holder. It just slipped out of my mind to get it from my clinic. The needle holder should be much smaller than this. As you can see, when I'm pulling, the thread is slipping from the needle holder. So you need a micro instrument even in the needle holder. And that allows you to work quite effectively. But it's all closed. If you want, we can give some supplemental sutures over here on the papilla. I'm going to go with my naked eye. It's sometimes too difficult to place there. You need a finer needle and suture. Let me retract a little bit so that I can see. All done. I hope the flap is sealed well. Let's check the flap. Is there any possibility of adding sutures? There is one possibility of adding a suture over here. I can just close that part as well so that on the mesial, I'm sorry, on the central. Possible to take it out. We have a tweezer. No, not this one. Small needle tweezer. Tissue forceps rather. Seems to have gone, no? Take it out. Try to go through the same tract, which you prepared with the needle, so easier for you to go. And it's a very small thread left, so you have to be a little bit careful. It's got tightened in the middle. Oops, cutting this. Fine, so we can still manage to finish the suture. I can use a smaller one. Okay, so all the sutures are given, and you can clean, flush, and is a flap approximated that you need to check. And you can see the advantage of 15C blade is like the closure is better. And now the pack over here, pressure pack, and course instructions. आने okay. Good, well done. अच्छा किया तुमने काम, पैसा तुम्हें मिलना चाहिए इधर बैठने का, हमको नहीं. All right.
चलिए 1 2 3 करो. A very good afternoon to one and all. First of all, the entire team in the operating room deserves a very big thanks from us, especially the stalwart like PD Joshi sir, who have been so patient and given us so much of time here to be in the operating room and guiding us and helping us. And thank you so much, sir, for executing the third day entire case with utter precision and perfection. This is the art that all the students need to learn and execute, all in the favor and in the best interest of our patients whom we are going to serve. And I hope that everybody will imbibe the technology, the zeal, the perfection sir has just manifested here. Thank you so much. And I thank Dr. Amrut, Dr. Unmesh, Dr. Shaili, Dr. Reshma, Dr. Vignesh, Mr. Gaikwad and his entire team for all the efforts they have made to bring this video and audio to you with such a perfection and precision. Thank you so much. Rajendra for helping us technically, and definitely not to forget the contribution from Sanjay Deshmukh sir, to whom we have been contacting every now and then for all his support that he has extended. A very big thanks goes to our Dean Madam, Dr. Vasundhara Bhatt, our Joint Director Dental, Dr. Pakmude sir, our Director, Dr. Ajay Chandanwale sir, our Commissioner, Mr. Rajiv Nivatkar sir. And this whole setup has been provided to us by special interest taken by our Honorable Vice Chancellor Madam in the university, and we have been reporting continuously all our matters to the Dean Academics in the University, Dr. Mrinal Patil. Thank you, all of you. And not to forget, as we come to the end of this enriching 3-day workshop on the live microendodontic surgeries, I would like to take a moment to express my sincere gratitude to each and every one of you. Your participation and engagement have truly made this experience exceptional. First and foremost, I would like to thank you all for registering with us, subscribing to our channel, to this workshop. Your dedication to advancing to your skill and knowledge in endodontics is commendable. And it's been a pleasure to see so many passionate professionals coming together to learn, share, and grow. Your comments, the ideas given to us, the flaws highlighted by you people have really put us to a positive path of development, advancing more. Believe me, this is one of the most advanced microscopic intervention center in the world, who has been active for 15 years, and your support and your comments and your suggestions and the flaws that you highlighted, suggested to us, will definitely fuel further progress, and it will act as fountainhead for newer ideas, newer avenues. The question asked by the beginners and the students have given us a new perspective of looking at the same things which have been doing for so many years here. We hope that the insight and techniques shared over the past few days will inspire to incorporate the latest advancement into microendodontic surgeries in your own practices. The journey to excellence in our field is ongoing, and its workshops like this will help us to stay at the forefront of innovation. We are committed to bringing you more such opportunities to expand your knowledge and refine your skill. Rest assured, we will be organizing many more workshops in the future, covering a wide range of topics in endodontics and beyond. So please stay connected with us and look out for our upcoming announcements. Once again, thank you for your active participation and being a part of this learning community. We look forward for seeing you in future session. Wishing you all continued success and growth in your professional endeavors. Take care and see you soon. The last announcement I would like to make to all of you on this occasion is that our next workshop will be on suturing. Suturing means selection of suturing materials, selection of suturing technique, different types of knots to be used in closure of the wounds. Soon we will come out with that video. Stay with us. Thank you so much.